everyone. My name is Dr. Uzma Siddiqui, and I'm at the University of Chicago. I want to thank our course directors, my friends, Drs. Krinsky, Riker, and Wynn, for the invitation to be a part of this great AWE annual course. Today, I'll talk about hybrid ESD. When I use the term hybrid ESD, I basically mean using ESD technique with a cutting knife to dissect into the submucosa and narrow the base of a lesion until you can use a snare and then apply EMR technique to remove it. For the purposes of today's talk, I'm going to focus mainly on colon polyps, but you can obviously use hybrid ESD throughout the entire GI tract. And in my mind, it's the best of both resection worlds, and I'll tell you why. Now, before you resect any colon lesion, the first thing you want to do is have a really good assessment. And the first question is, do you think there is cancer in this polyp? Specifically, is there deep submucosal invasion by being very depressed or having a non-granular amorphous appearance as you see here? Because these can indicate submucosal invasion that has a risk for lymph node metastases and perhaps should not be removed endoscopically and need surgical resection with lymph node sampling. But if you think it's a benign lesion or there might be a superficial cancer, then you can consider endoscopic resection. And again, if it's an early cancer, you want to get it on block so that you have a better specimen that's easier to interpret for the pathologist. You also want to assess how big the lesion is, how many folds does it cover, and where is it located. Specifically, lesions in the rectum that can be polypoid or bulky may harbor malignancy, and you want to possibly consider getting those lesions on block so that you don't have a situation where you have a positive resection margin and you have to question whether complete removal was achieved. Everyone's familiar with EMR as a technique where you perform a submucosal injection underneath the lesion to lift it up and away from the muscle layer to hopefully prevent any injury. Then you use a snare to resect the lesion. Everyone has their own preference as to what they like to inject into the submucosa. I prefer to use a viscous solution so that it stays lifted or elevated for a little bit longer. And then obviously you can use a submucosal injection needle. And some of the ESD cutting knives also have the ability to inject as well. I always try to use a distal attachment cap when I'm doing endoscopic resections for a few reasons. It helps with traction and maintaining your scope position. And also, if you have a lot of bleeding, then it can help localize the vessel that you want to target for coagulation. In terms of use of snares, I always use a very stiff snare, specifically a monofilament snare, and I never use anything that's over 2 centimeters because at that point, you're applying so much thermal energy to the tissue for larger lesions that you're at risk for perforation when you use bigger snares. Cold snares are excellent for resection. They are a very thin wire. The main downside is that they're usually only 9 or 10 millimeters in size, so you have to be careful to not leave any intervening pieces of tissue between your resection pieces. This is an example of a large ascending colon EMR. First, you want to assess the lesion. There doesn't appear to be any obvious submucosal invasion or features of that. It looks like a benign villus adenoma. So I usually, for large lesions, start my submucosal injection and resection from the distal or anal side of the lesion. Here you see a really nice lift, and then the snare is going to be applied. And I always start on one side of the lesion. You try to get a little cuff of normal tissue as well. And then once you take the first piece off, then you can use the edge of that resection site to put your snare and get the next piece. And then you will continue the process where you inject, then cut, and then continue to inject and cut as needed until you've worked your way through the entire lesion. Key here is that you try to place the snare right on each resection edge and get to the base of the lesion so you don't leave any intervening pieces of tissue. Now, ESD is a little bit different technique. Again, you have a submucosal injection, and then you're going to use a resection knife. There are a number of cutting devices and knives on the market currently. You obviously don't have to be familiar with all of them, but you should know how to use a few of them, and in what particular circumstance might you choose one knife over another. Oftentimes with ESD, you do need some sort of traction to be held to aid with dissecting the lesion away from the submucosa. In the US, there is one that's FDA approved, but a lot of times you kind of use makeshift traction with dental floss or rubber bands and clips. This is an example of an ESD. This was a bulky rectal lesion. Outside pathology suggested possible intramucosal cancer. It ended up actually being a T1A superficial cancer. But because of the potential for malignancy, I wanted to do an ESD to get an en-bloc resection. So you saw a mucosal incision, then dissection into the submucosal layer. There always is going to be some level of bleeding because a lot of vessels live in the submucosa. And here you see coagulation graspers with soft coagulation being applied to seal off that vessel. And then the dissection continues until the lesion is completely gone. Now, the reason why ESD is great for these early mucosal cancers is because with an en-bloc resection, you have a higher chance of getting an R0 resection, meaning your margins are all negative. And for the pathologist, it's great because it's much easier for them to rule in or out cancer and assess margins when it's one piece versus 20, when you have a piecemeal EMR. The other advantage of ESD over EMR is that you can dissect a little bit lower into the submucosal layer, which then gives you more information about lymphovascular invasion, which then helps you prognosticate the risk of recurrence in your lesion. The disadvantages of ESD is the time. It is very time consuming to individually dissect submucosal fibers and the lesion out off the wall. There is, in the US, no billing code for ESD. There is a higher complication rate with perforation rates as high as 5%, as opposed to less than 1% with EMR. It's just technically challenging, especially for larger lesions and when you have to use traction, and you need a lot of training, whether it's observation or working on live models or being proctored. Now, in the US, there's no set guidelines on how to train for ESD. So at our institution and my own experience, I did a few courses. I practiced in animal models. I went to the National Cancer Center in Tokyo to observe cases, and our own ESD data is similar to Japanese guidelines, where you probably need 40 to 50 cases to where you're going to get good en-bloc resection rates that are over 85%. And one thing to notice also in our series on ESD training, the average procedure time was almost 2 hours. So you have to think about that when you're planning these procedures, especially if you have an otherwise busy endoscopy schedule. So how can we get around some of the disadvantages of ESD, but still maintain the benefits, which is getting en-bloc R0 resections? So that's where hybrid ESD comes into play. So your goal is en-bloc resection. And in this case, compared to standard ESD, when you do hybrid ESD, you can essentially do your mucosal incision. If you can get it circumferential, that would be great. And then you can dissect into the submucosa all around the base until it's small enough that you can apply a snare and resect it in one piece. Technically, that is easier, a shorter procedure time, and less need for traction. The disadvantages are potentially, depending on how your dissection goes, you may still not be able to get an en-bloc resection with your snare, and you may not get as deep into the submucosal layer right at the base where you do the EMR portion. So this is an example. Again, a lot of times I'll use this technique in the rectum because those are the lesions I want to get out en bloc in case there is any incidental cancer found. So we're going to do hybrid ESD. We did a submucosal injection, and then you see the ESD knife doing a mucosal incision all around, submucosal dissection. And there's no set amount of how much you need to dissect. So you kind of have to subjectively look at your resection site when you think you have dissected far enough down at the base where a snare can fit around it successfully. Again, I still prefer to try to dissect enough that I can use a 2 centimeter or 1.5 centimeter snare and get around the base. Another area where I think hybrid ESD plays a role is when you have a polyp right at the anal verge. A lot of times the lesion will be very tacked down and fibrotic right at the anal verge, and it may be very hard to lift. There may also sometimes be hemorrhoids. So it's nice to use ESD techniques and a cutting knife to cut the lesion off the anal verge and free it up. You can see a lot of fibrotic strands here. And we can, cauterize a little bit as we go. And once we've been able to dissect all the way around this lesion, then you can apply your snare to the base. And, the benefit here is that the base is so much smaller now than even the top portion or bulky part of the polyp. And usually you can get your snare all the way around it. Now, sometimes lesions are just very scarred down from prior manipulation and hard to lift. So what do you do in those circumstances? University of Chicago, you came up with this D-scar technique to try to handle these types of lesions. Again, it's a variation on a hybrid ESD technique. You essentially use an ESD knife to dissect around the scarred portion and a little bit under the base where you deal with a little bit of the fibrotic strands and then apply a snare at the very end. Here you see a scarred down lesion. And so you do a submucosal injection, mucosal incision, and then continue your submucosal dissection until you have really isolated the center piece of the lesion. Once you've isolated the scar down lesion in the center, you essentially have a moat or, the scaffold where you can place your snare. And then now it's a little bit easier to just resect that lesion in one piece. And you still have a clean resection site. Now, our initial data with this technique showed that most of the lesions had been previously manipulated with biopsy, resection attempt, or tattoo, but we still had a 100% success rate despite that using this D-scar technique, and follow-up on a total of 57 patients over 4 years showed similar high success rate at 98%, and only a few adverse events, including 2 delayed bleeds and then 1 small perforation managed endoscopically by clips. Well, what about outcomes of using hybrid ESD versus conventional ESD in different locations? If you look at using hybrid ESD in the cecum for large laterally spreading tumors, as opposed to conventional ESD, this particular study showed shorter procedure times, but similar bleeding and perforation rates. And then also in the stomach, here we had smaller, less than 2 centimeter early gastric neoplasms, and this was actually a randomized controlled trial. Again, they showed shorter procedure time, but similar efficacy and safety profile. And this is just an example of a hybrid ESD case where there was a gastric lesion in the proximal body, and there was a question of it being possible lymphoma, but the biopsies were inconclusive. So I was asked to resect it en bloc if possible. During the resection, it was very hard to lift. It was a little bit tacked down by numerous blood vessels that continue to ooze and actively bleed during my ESD. So because of the ongoing bleeding that was slowing me down, what was originally planned to be a standard ESD, I turned it into a hybrid ESD and ended up snaring off the majority of the lesion because I needed to handle the bleeding. So I did get an en bloc resection. There was active bleeding. I couldn't find my resection site again, so I used a hemostatic spray to slow things down. I put an over-the-scope clip once I found the resection site, but it just made things worse in terms of bleeding. And then after staring at this pulsing stream of blood, I placed another over-the-scope clip, stopped the bleeding, and little hemostatic spray at the end for good measure. But based on the limited existing data, hybrid ESD is a good alternative to standard ESD in terms of efficacy and complications, but it will give you a shorter procedure time. So a few key take-home points. Most colon polyps that are encountered are benign and can be resected endoscopically with almost any technique. Hybrid ESD should be considered as an alternative to standard ESD in lesions that could potentially be early cancers where the margins are extremely important, or in lesions which are severely scarred down from prior manipulation and may have a lot of fibrosis. You can incorporate ESD techniques more easily into your daily practice using the hybrid technique because it's a little bit less technically challenging and takes less time than standard ESD. And as with any endoscopic technique, you need to know your equipment and be aware of potential adverse events. And with that, I'll stop. Thank you.